afternoon and good evening to our speakers, chairs, and audiences of ACNS webinars in different parts of the world. We are back again with another session of ACNS webinars for you. First speaker for today is our honored guest from India, Professor Anirudh Kumar Purohit. Professor Purohit is a senior consultant neurosurgeon at the Aster Prime Hospital, Telangana, India. He was the former professor and head of the Department of Neurosurgery at the Nizam's Institute of Hyderabad. He is a founder member of the Indian Academy of Cerebral Palsy and Indian Family of Cerebral Palsy. Professor Purohit is a noted author with several publications in journals and book chapters. He is the recipient of several awards and honors that he has received for his outstanding contribution towards neurosurgery. We are extremely honored to have him today as a speaker for our webinars, and he'll be talking about peripheral surgery for cerebral palsy. The speaker for the second session of today is our honored guest from Zimbabwe, Professor Kazadi Kalangu. Professor Kalangu is the professor and head of Department of Neurosurgery at the University of Zimbabwe College of Health Sciences. He is a member of the Education Committee of the WFNS and is also the former second vice president of the WFNS. He served previously as the president of the Association of Neurosurgical Societies of Africa. He is a member of the Belgian Royal Academy of Medicine and also the honorary president of the Continental African Association of Neurosurgical Societies. He has received several awards for his dedication towards neurosurgery, including the Medal of Honor of the Association of French Neurosurgeons. We are extremely honored to have him today as a speaker at our webinars, and today he'll be talking about simple and reliable technique to prevent VP shunt infection. The chair for the first session of today's webinar is our distinguished senior faculty from China, Professor Liang Shen. Professor Shen is the professor at the Department of Hand Surgery at Huashan Hospital, Fudan University, Shanghai, China. He is a senior neurosurgeon and an integral part of the Chinese Medical Doctors Association. He is a noted author with several publications in various peer-reviewed journals. We are extremely honored to have him today as a chair for the lecture of Professor Purohit. The chair for the second session of today is another distinguished faculty from India, Professor Chris Sridhar. Professor Sridhar is the director of the Institute of Neurosciences and Spinal Disorders at the MGM Healthcare, Chennai, where he has set up a neuroscience department capable of world standard clinical and academic neurology and neurosurgery. He has several publications in international and national peer-reviewed journals. He has edited textbooks of neurosurgery and operative neurosurgery and has contributed to several chapters in neurosurgical books. He has traveled extensively, delivering lectures on his areas of expertise that include cervical spine, skull base, vascular neurosurgery, and neuro-oncology. He is a member of the executive board and council of several societies, including the NSI, ISNO, Skull Base Surgery Society of India, and Association of Spine Surgeons of India. He has been the organizing secretary of the annual conference of Neurosurgical Society of India at Chennai in 2016 and the president of the first virtual conference of the Asian Congress of Neurological Surgeons in December 2020. We are extremely honored to have him today as a chair for the lecture of Professor Kazadi Kalangu. On behalf of the Education Committee of the ACNS and the President, Professor Yoko Kato, I would like to welcome both the speakers, chairs, and audiences to this online platform of ACNS webinars. Dr. Liu Boon Seng from Malaysia is my co-host for today. And with that introduction, I would like to hand over this platform to the first chair, Professor Liang Shen.
Now it's time for me to present over the first session. Hi, everybody. I'm honored to have the opportunity of presenting over the session that is the cerebral palsy. The cerebral palsy is a non-progressive, non-hereditary encephalopathy that is characterized by the altered motor sensory and often intellectual function. In pyramid pattern, it includes the spastic hemiplegia, diplegia, and even quadriplegia, while in extrapyramidal, it includes ascetoid and ataxic patterns. There would be also a mixed variety with spasticity and ascetosis. Peripheral surgery for cerebral palsy includes nerve transfer, for example, transfer of the supinated branch to the posterior interosseous nerve to reconstruct thumb and finger extension, and even a neurotomy can be used. Peripheral surgery also includes palliative operations such as myotomy, tenotomy, tendon lengthening, tendon transfer, and so on. And even the arthrodesis can also be used. It is believed now that results of peripheral operation for cerebral palsy depends on appropriate patient selection. Now we would invite Professor Purohit from Nizam's Institute in India to lecture on peripheral surgery for cerebral palsy. Now, Professor Peripheral, please.
Greetings from India to all of you. Thanks to Dr. Singh for a nice introduction regarding cerebral palsy, the possible peripheral methods, as well as my introduction. Let me start with the peripheral neurosurgery for spasticity and dystonia. Why am I talking about only spasticity and dystonia? Because these are the two which can be definitely controlled with the help of peripheral surgery. There are various other topographical types where we do not find that there will be much of the improvement with the peripheral surgeries. However, let's keeping this neurosurgery as an ablative procedure in our mind, we go ahead with the history. Now, it is interesting to note that the little, as an orthopedic surgeon, he started jetplasty. Then in 1987 came obturator neurectomy, then vesicular rhizotomy, then anterior rhizotomy. And like this, if we can see in more than 150 years period, lot many changes have occurred. Lot many procedures have come into vogue, and they have, some have existed, some have gone off. So what is happening is that with some of the methods, we climb for the better results, and suddenly something happens. Perhaps there is a honeymoon period in which we are able to go ahead with a great zeal and enthusiasm with that particular procedure. And after some time, we realize, looking honestly with the results, that there are only a small percentage which are good. So this is, we climb for something good, but then suddenly we may come down also because of the failure of some of the operations. And that is the reason that more than 150 years now that the various methods are coming into work. The important thing is that, as very correctly mentioned by Dr. Liang Shen, that it is a central problem. Brain, insult to the brain. And what we are going to talk about is peripheral solution. So these inhibitory impulses, which are inhibiting this volcano anterior horn cell, and then this particular has become hyperactive in cerebral palsy, and that we will now see that how we can tackle this particular positive, which has become hyperactive, as a peripheral solution, till we come to a real treatment of neural tissue transplant. Many things are coming now, rejuvenation of the neural tissue, stem cell and whatnot, but then still for a human practice, they are not fully proved. That is the one basic thing which we have understood. Then please remember that these surgeries are at the different age of these children, because the challenge is that this is a growing age, and in the growing age, you are going to tackle various pathophysiological disturbances which these children are having. So in general, you will find that the whole life they are up to the age of 18 working on these children, and non-ablative procedures remain more in vogue initially, and then the ablative procedures. Actually, after the age of 8 years, one can think of these musculoskeletal procedures. Before that, we have to think of a neuro procedures of SPR or SDR and SMF, etc. And non-ablative procedures are also again from the early age till the age of 14 or 18 or 20 years. So this is the another challenge, that when we have to intervene for these particular individuals with cerebral palsy. So keep in mind that still we are not able to go to the permanent, better and best solution of treating these children, these individuals with cerebral palsy. So short of that, till we get the neural tissue transplant and other things, let's hope for the best. The other challenge is that there are so many types of cerebral palsy. You know, polio, flaccid paralysis, that's all. But in these cases, we find that there are various types. So very correctly mentioned by Liang Shen that we must know how to select pathophysiologically as well as demographically these individuals. So physiotherapy remains always, various medications also come into picture about it, and various surgeries, ablative procedures come into picture. And that is the reason that there is another challenge, that there are so many treatment options are available, and you have to select the best for the child. How will you do that one? Say the TBS, spinal cord, intrathecal baclofen, they all are on the upper motor neuron to stimulate. And let's see if we can bring more inhibition here. And the other non-ablative is botulinum toxin. But the problem with all of them, if I look into the whole of the world, that the most of the population cannot afford for these very expensive methods of non-ablative type, one. Second, there is a dependence on the doctor that these, say ITB, every 1 month or 2 months, you have to go and get injected for the baclofen. And these machines have to be maintained by the doctor. Not only this, there is a geographical constraint to take the patient when they are grown up also. And that is why I think presently, today in the world, if we talk about living exceptionally, some of the population of the developed countries, these are not the good methods from the socio-economical and geographical point of view. That's good. That done can be undone. The system is still intact. That is the greatest thing of these. But then these are the methods which are one-time method of selective posterior rhizotomy or selective motor fasciculotomy or something on musculoskeletal, say soft tissue release surgeries, etc. So these are one-time method and less expensive, no recurring expenditure, and to the best results that they are not recurrence also. So today we will be talking more about rhizotomy, fasciculotomy, and I will say that it is very important to have in our team what is called as plastic and orthopedic surgeons also. Then so many things are there. Now there is a problem of this thing, and that is the professionals are biased with what they know, and the families are confused as to what is the best for their child. And that is the reason that some of we again keep only the one which we know, practicing that one. And that is why there is a very important aspect of neuro ortho plastic team along with non-ablative procedures like physiotherapy, occupational therapy. People should be in the team. As I mentioned, that more of ablative procedures we are going to talk about, whether it is a rhizotomy in the cortoequina or in the peripheral now, say, for example, tibial now, and the orthopedic procedures are complementary. We are complementary to each other in bringing the best results. Most important thing is that this ablative procedure, whether it's SMF or SPR, is on a non-progressive disorder, harmful dystonia or spasticity, and it should be resistant to non-ablative methods. Then only this particular procedures, ablative procedures, should be thought of. Tell me, what will you do for such a child who comes at the age of 8 years with the spasticity? There is a severe equinus, and because of that, he is also bending, and then something is done that he improves. And after a year, and then something is done, and then he continues to walk. So what will you do for such a growing age person when one after another any problem comes? Like in a garden, if a plant is growing, you only cut to that which is causing the problem, not that the whole of the or so much trimming is done. And that is what I would suggest, that we have to go stage by. First, we did bilateral tibial selective motor fasciculotomy and jet plastic. That time we were doing jet plastic. Now we have gone more for an aponeurotic release. After 1 year, sciatic SMF, and at the just before 14 years of age, when he has fully grown and spasticity is mostly controlled, we have gone for bilateral hamstring release. Just simple release was good enough in this boy, and now he is more than 24 years old. We'll now have a look on this particular video, and you can see her elbow is very badly flexed. She is unable to extend it, and shoulder is in abduction. There is an hyperpronation. Now, most harmful is the elbow flexion. She has undergone earlier foot and hand surgeries also, and there was a lot of recurrence. I must tell you, for a dystonia, one should not think of the orthopedic procedures, muscular procedures as the first stage. Well, this is what we did, and she is able to, voluntary movement is possible after musculocutaneous fasciculotomy. This is very difficult to develop a voluntary movement, and we were very happy to see that one. And not only this, you can see some scar here, which was the previous orthopedic surgery, and she has even the pronation, voluntary, and they have a trick to open their hands. All of you will find that these children develop a lot of tricks how to use their muscles. Well, so we go to the next one. So this is what is the position. All the limbs should be exposed whenever we do. This is what is the musculocutaneous nerve was exposed and dissected, and this is what you see, the corduroy kind of an appearance of the nerve, and these are the various fascicles, those which could be easily dissected, and then they are followed up to the muscle, and then some of them are ablated. This is say calf muscles, MGM, LGM, and the soleus there. This is the sural nerve, and we go for these particular fascicles and then selectively section some of them. These are the various movements and various muscles and various nerves. One has to learn this thing very well, first thing, and then clinically that which one is harmful. So let's talk about what will you do for this boy. 4-year diffuse spasticity, both lower limb, no contracture, good motivation, and is having a diplegic gait. And she has gotten focally harmful equinus. He has diffuse spasticity in both the upper limbs. So what will be the procedure of choice in these cases? These are the procedures. Selective posterior or selective dorsal rhizotomy. This is tibial SMF, and here bilaterally in both the upper limbs, you have to go for selective motor fasciculotomy because the rhizotomy for the upper limb is not well accepted procedure we have done earlier. Let's now talk about if somebody has a dystonia and it is a segmental or focal dystonia, another one has a diffuse dystonia. So what will be your choice of surgery intervention if all other methods have failed or resistance is developed? This is again a case of selective motor fasciculotomy, and she is a candidate for intrathecal baclofen pump. We have experience for both of them. Now, peroperatively, it is very important you to see that how much is the dystonia and how much is the spasticity, because most of the time you will find that the spasticity and dystonia both are together compared to those DOPA responsive dystonias. So that is what we do on the table, and we find that there is a spastic element along with this. So we operated her, and here at the elbow is increased. We have seen that what are these movements occurring. This girl will show you later that how she injured with her own nail, her own thumb, and that is why we are trying to reduce the dystonia and spasticity of the finger and the thumb. You can see how secondarily there is a wrist flexion also. So not many such observations are very, very important. Again, there is a trick that how you should be able to really see the exact movements which are occurring there. And this thumb, this finger, which were mainly harmful in this particular girl. Right. Similarly, on the table, we will be able to see another movement through the median nerve itself. This nerve has so much supply, and you can see so clearly there is a pronation movement is visible over there. Similarly, other movements, not only of finger, but you can see about the wrist flexion also. That this is the, without finger flexion, there is a wrist flexion. Earlier in this case, there were the finger, with that there was a wrist flexion. That is a secondary wrist flexion, not the primary one. What we want to say is, this is in Ramamurthy Tandon, our first textbook of the neurosurgery, published around 40 years back. At that time, we have printed this particular 30 years back. And this is what is now we are doing for our research work in the cadaveric dissections, and how each and everything has to be measured. And then we have to decide that which particular one has to be cut, how much to be cut. This is, as I told you, about the tibial nerve and popliteal fossa. This is the position in which you have to operate with a sciatic or popliteal in popliteal fossa tibial nerve. This was actually often shoulder dystonia, and we have taken trapezius nerve here, trapezius muscle, and operated that way. Earlier, we were using the microscope, but right now, even a loop is enough. And earlier, we were very much having our neuropaque machine, through which we were gradually increasing, and then we were testing the movements. But now we do not go for that one. After that, we came to a very small particular nerve stimulator, but now we go more for our what is called as mechanical stimulation, and we are able to see the things for the motor ones. This is the fasciculotomy, which you have already seen, and we will not go into much details of it. You can check it up that how on the table we are able to demonstrate various movements and how to ablate a particular fascicle. That is what is being shown over here. You can dissect it, you can test it, and then you have to cut. And we apply a clip over there so that no recurrence occurs. And later on, if we have to go in again, the finding out that particular fascicle is easier. That is how it is being done. So this is the electrocoagulation of it. And till it becomes brown, not the black, we keep coagulating it. This is another girl of a dystonia where she already underwent surgery for her equinus long ago, and now she has come with the problem, and very difficult to use this. And important thing is that because of this more affected hand, the upper, which is a little better hand, also get disturbed. This is an interesting part in dystonia, these candidates. So they have a good motivation. This is what after surgery, when we have operated, she is the affected hand is not disturbing her, and she is able to very easily use her less affected hand, and that is what is the particular post-operative of this particular. But more interesting part in this case was that she actually came with the self-injury. Uncontrolled movement of the index finger has caused this injury, and then how with these surgeries, with the lax fingers, you can see how tightly he has to hold these things. and then it has improved, and this is what you saw just now, that she is able to do well. This is another dystonia. The mother is mimicking over here that how he was earlier, that he improved post-operatively with this particular movement has come. He started holding it, he started flexing like this, otherwise he was not able to do, and also is able to do the work with the less affected hand because the other one is not disturbing. These are the pre-op, and so many activities of daily living has improved after fasciculotomy. This is a dystonic, and this is the spastic one. His hand is free after the surgeries, and equinus is gone. Here also you can see she's so much grown up now, around 16-year age, and she has to keep this particular hand because of the dystonia and spasticity under the another hand, very much disturbed. And then we operated, her hand has become very much free, upper limb is free. She is better to do the work with the normal hand also. She did require orthopedic procedures, simple orthopedic procedures during this. This was our 1998 when we published our first publication in Acta Neurochirurgica on musculocutaneous nerve. And you can see that how spasticity has reduced in wrist flexors and how selective voluntary control has improved post-operatively after SMF. And this is what the functions have also improved. Even the finger functions also we have evaluated, and we have found that there was always an improvement post-operatively with these. This is another series of 41 cases, and I will not go into much detail, but you can see that how these patients, children have undergone the surgery of various nerves, upper limb nerves, and we will go to that how this spasticity mass has reduced and how the selective voluntary control has improved even for with the musculoskeletal elbow flexion. So like this pronation also and wrist flexors also, every time spasticity reduces, voluntary functions do improve. And these are some of the post-op improvement in them. What ultimately we say that reduces spasticity and unmasks the residual motor function which they have actually, as you saw in dystonia, that how she could move her pronation was possible. And passive movements are easier. Appearance improves very much. Even sometimes a cosmetic may be the only thing for which we can operate these individuals. Functional activities of daily living we have seen. And these, there are hardly any kind of complications or recurrence of spasticity or dystonia. So this is what we have concluded, as I told you, and complications of wound or sensory disturbances or recurrence are nil. So this was our outcome of motor fasciculotomy in the treatment of upper limb spasticity, which we published in around 2011. And these are the various other authors which the literature has helped us also to refine our techniques. And we presented in ISPN in Germany in 2013 and got the E-Poster Award. Well, now we come to another entity, and till now we talked about selective motor fasciculotomy. One thing I forgot to mention that you may refer to as a selective neurectomy also, but please, mindset is very important. If you mention neurectomy, nerve cutting, instead of that fasciculotomy, the surgeon mindset plays very important role that you are going to cut only fascicles and not the nerves. So better word, which we coined in 1998 and got accepted by Acta Neurochirurgica. So what will you do for this child? Diffuse spasticity, both lower limbs, and the surgery which is helpful for these cases is rhizotomy. This you have already seen fasciculotomy. So let's concentrate on rhizotomy. Positioning has been done, and you may find I will go a little faster for this. Hopefully, here in a chorda equina, the posterior root is dissected from the anterior root, and from the posterior root, we have to select the root length. Depending on the severity of spasticity, control, contracture, other procedure which might require in the future, the percentage of the rootlets are sectioned. So this is how we identify the posterior root, which is broad, paler, and anterior root, which is round, smaller, and more pink. And naturally, the position will be different. If you can see that we have to immediately put a patty between the two, or a lint between the two, anterior and posterior, and then start stimulating and see which clinically you found was harmful. That particular one has to be sectioned. So usually L5 is of a posterior, L5 is a knee flexion. Most of the time, L5 knee flexion, S1 is the plantar flexion. But then they superimpose on each other, but predominantly you will find S1 plantar flexion, and here knee flexion is this. Very interestingly, toe flexion is also seen nicely, where it slowly moves like this. That is S2. So we decide from usually L4 to S2. Sometimes we go for L3. Just L5 laminectomy and caudal L4 laminectomy is usually good enough in most of the cases. So the spinal dissection also becomes very less. We can show you some other movements, but hopefully the rootlets which have been dissected are understandable with this video. But it is not very difficult at all for the surgeon. You have to just cut through and through, no coagulation required here, as we do in fasciculotomy. So this is the nerve stimulation of L5, and you have already seen just now. We are showing you again. Perhaps we can move faster on this. S1 also, which you saw as a small video at that time. This is, and some of the knee flexion also is being seen. And you know that this is a muscle which travels two muscles. So you can see when calf muscles contract, the other one will also contract. L5 root you have seen already. So this is rhizotomy for diffuse spasticity of the lower limbs when the trunk control is good. But this is not an ideal candidate because of the reason that he has developed a lot of contractures also. So once we have controlled spasticity, then he underwent surgery on the muscles. This is another girl, how the crouch, and then neuro-ortho intervention. Similarly here, neuro-ortho intervention. And this is what is our neuro-ortho team. This is particular picture is from the Mumbai, where we operate in our orthopedic colleagues. So what I want to say is that the lot of hard work is required by the team, the individuals in this particular field of neurosurgery. We started our journey in 1988 with the help of Dr. W.J. Peacock, who conducted workshop in India. And this was that time in 1988. Then we started the camps all over the country, and many camps, and started spreading the awareness about this particular disorder. And then in 1994, we made an Indian family of cerebral palsy, and looking after them, and went even to Japan. At that time, the rhizotomy was not being done, and we were doing only rhizotomy, not fasciculotomy. And then in 2004, we developed Indian Academy of Cerebral Palsy, and then we demonstrated this fasciculotomy in Florida with Dr. Jogi Patisapu, and because he was very good in already doing rhizotomy, but when he came to India and he saw these surgeries, we went there and demonstrated our fasciculotomy there. So I reiterate again that we should not be biased with what we know. We should invite the noble thoughts from all over and create a team so that the family should not get confused that what is best for their child. A good talk, a good discussion with them is very necessary. So I think still this field of cerebral palsy management will continue. and we will arise, awake, and stop not till the goal is achieved, is the greatest slogan which is given by the Indian monk Swami Vivekananda. And very important in this whole scenario is be positive in our life, stay motivated, and we can see many children are there whose hands are not good, even feet have been replaced by the hands, and they are contributing tremendously. Just yesterday here in Rajasthan, I saw another girl, I don't have a photo, but she is using her foot to remove and put the mask, and she is eating with the biscuit. Another our rhizotomy boy who became doctor and have got married is a great pleasure at this age when we see that what the fruits are growing up, because the ultimate aim of any rehabilitation is vocation. They should get a job, vacation. Now they should be able to go for the entertainment and relation. That is vocation, vacation, and relation is our slogan. Now we have sites where all those children who have been operated long ago are a part of it. So I thank you once again for all this contribution by Dr. Raja's efforts and the Nizam's Institute of Medical Sciences, and then as a freelancer along with Esther Prime Hospital of Hyderabad. Grateful to all of them. Reiterating, please keep in mind various options, various challenges, and we all will be able to meet with it. Thank you. Namaskar.
I just ask her, I'm a hand surgeon, I am a question to Professor Purohit. As far as surgery for the swan neck deformity, which operation do you prefer? I mean the intrinsic lengthening or the central slipper tenotomy, which is more effective in your experience for the swan neck deformity?
This is absolutely
yes.
with the orthopedic surgeon. They take care of any Schwann neck deformities of the fingers. I have not touched till now any of the Schwann neck deformities of the fingers. So they do some procedures for the thumb also. There are some of the procedures, web widening in one of this child which you have seen, which I showed you, dystonia. So I will not perform for Schwann neck deformity any of the fasciculotomy. Over to you.
All right. Thank you.
And what will you do? It's interesting.
Yes, yes. In our experience for the swan neck deformity, we will do the central slipper tenotomy, where the central slipper tenotomy, and sometimes it is I would say it is effective.
Yes.
Yes.
Absolutely. So that's right. I think that is, I also would prefer that one. But I heard initially when you tell some nerve transfer in these cases, I have not done any nerve transfer for any of these cases. Do you do some nerve transfer for the relief of spasticity or dystonia?
Most of our cases is in our unit. We the cerebral palsy in our case for hand surgery, we always found that they are spastic. They are spastic hemiplegia. So the tenotomy is more often to be performed.
I think if you try first relieving spasticity, and then if the muscles are weak, then the other side of the muscle can be brought as a muscle transfer. That is what in some of the cases, but still I feel that the main cause of spasticity is first to be relieved, because sometimes it may cause the problem in the surgical results also. And it will be much complementary if first fasciculotomy is done, then physiotherapy, occupational therapy, and then whatever weaker muscle is there that can be replaced by the antagonistic muscle. So that is, I feel that would be much better.
And also, a more question: Do you do any nerve transfer? Do you do any nerve transfer for the spastic, the hemipalsy for the?
No. I don't do any kind of nerve transfer. I don't believe that is required. Only after relieving this spasticity, if some weakness is there, then a stronger muscle can be brought on that side. But perhaps I heard you in the beginning when you were introducing, you said perhaps nerve transfer. So I was very much interested to know if there is something of that kind of thing is available.
Good, thank you.
Here's my co-host, Dr. Liu Bun Singh, who would like to ask.
That would be good.
Yeah, thanks, Raja. Thanks, Professor, for very fascinating journey and treatment. May I know, Professor, I see that you are doing more of physical testing during the surgery rather than any form of EMG or some neuro monitoring. And classically for spasticity, he was told that you cannot do a rhizotomy, motor rhizotomy for more than 50%. So may I know what are the tricks and tips for you, in deciding how much rhizotomy that needed for spasticity? And my second question, Professor, in terms of you were talking about the technology regarding deep brain stimulation. Some device probably is not accessible to certain countries. May I know that based if say one day those devices become available and affordable, will you think that you will go towards the central stimulation than peripheral surgery for dystonia? Thank you, Professor.
Thank you, Dr. Luis. That is both are very, very interesting and important questions. And I appreciate that you have come to the how much to cut. That is the actually challenge for every surgeon. And here it plays most important role is your clinical examination. So say, for example, if a particular child is a very ideal child of spastic diplegia and walking with the diplegic gait and good motivation, no contractures, I will go with the 50% of the sectioning in general, right? But if we get many of them as an 8-year, even 10-year age, then it becomes a possibility that we may cut less because we might go not to the sensory ablation, later on residual spasticity in the lower limb, the motor side of the circuit. So, and some muscle lengthening like an aponeurotic release. So I repeat, in more challenging cases, which are not the ideal cases, we do not ablate so much, say 60%, 75%. Still we keep, say, maybe 35 to 50%. And we keep a provision of, instead of sensory part of the circuit, we go to the motor part of the circuit and slightly ablate to the fasciculotomy. But at the same time, at that age, we also give a chance of some aponeurotic release. So this combination plays important role when it is not an ideal case. Similarly, in fasciculotomy also, we will never go more than 50%. It will again be less than 50%, but we try, if possible, to combine with some of the simple soft tissue release surgeries. Perhaps I have given the answer, but many things will depend how much is the control in the limbs, what is our goal, whether palliation or what. Like this, many other items will be a full session on this aspect. Second question, appreciate. As you said, if all over the world, everyone is able to afford, there is no constraint to take one to another place. So no socio-economical constraint. Yes, definitely non-ablative procedures will be the preferable ones. And we have done intrathecal baclofen here and dystonia, whatever residual spasticity we have combined in them, the fasciculotomy. But in a few cases, we first did intrathecal baclofen pump, and we improved the control in the lower limbs, and then we removed the pump, and then we saw how is this spasticity, and then we did rhizotomy. So many hybrid and multiple things have to be thought of. But undoubtedly, I am for the non-ablative procedure, because this is the whole pathway is innocent. It is only the flow of impulses is more. So if we can control by other methods, yes, preferable. Agreed with you.
Thank you, Professor.
Thank you very much. Indeed, it was very, very interesting. And the kind of work that Professor Purohit does is really that something everybody should take a cue from him. Going down into the society, curing children, it is really admiring. Thank you very much for showing us the different kinds of surgeries that you do. We'll wind up this session. And now may I invite Professor Krish Sridhar, the second chair of the second session, to say a short introduction and in turn invite Professor Kalangu.
Thank you very much, Dr. Raja, Dr. Boone, and of course, Professor Kato for this opportunity to chair a very interesting session, and that too by a speaker like Professor Kazadi Kalango. Now, we all know that shunts are a very commonplace surgery. They've been done from the 1950s, but shunt infections still remain a problem and one of the more dreaded complications of shunts. The rate of infection ranges from between 10 to 22% in literature, and most often we see that the shunt infections come to light in the first 1 month or so, and the Staphylococcus group of bacteria are the one most commonly who are the bacteria which cause the infection. There are many risk factors, but then what I'm going to do is request Professor Kazadi Kalango to give his views on shunt infections and how, in his mind, he thinks these can be prevented and their incidence be reduced. So over to you, Professor Kazadi Kalango.
Thank you very much, Professor Sridhar, for your kind introduction. I'm going to share my screen. Thank you very much for the invitation, Dr. Raja, Professor Kato. It is my honor to be part of this talk, and which I appreciate a lot. And I've been always very fond of this organization, and which is really important for us. And of course, teaching young neurosurgeons is really our passion, because that's our future. I don't know if my screen is seen now.
Yes, you may make it full screen, Professor.
Okay, let me put the full screen now. And okay, that's good. Can you still hear me?
Yes, of course.
Okay, thank you very much. So I'm going to talk about prevention of shunt infection. And at the end, when we are discussing, I will tell you how we got to this protocol, which has helped us a lot. And it was really by chance. And the most important thing is when there is this kind of chance, the genius is the questioning of that chance. That's what happened exactly. A classification of shunt, we all know that the classification of shunt infection, either there is a wound infection, which is following the track with the incision. There can be infection from the CSF infection because of meningitis or ventriculitis. Can be infected shunt system itself. And of course, you can have abdominal complications. We are not going through to all of those complications, which we all know. And as the chairman has just said, the organisms, the most common organisms are Staphylococcus species, Coagulase negative and Staphylococcus aureus. And of course, there are also other bacteria which are usually causing that infection. And as you can see, in 67 to 85%, they are mostly Staphylococcus. And when we talk about Staphylococcus species, we know that the colonization of the shunt comes from the skin flora. The CSF shunt acts as foreign body. In fact, when we say skin flora, yes, there is a skin, but also all the glands which are on the skin, particularly the gland, the sweating gland. That's very important also to remember, which we know exactly. As the chairman said, you see there is this publication which showed clearly that the infections, they occur mostly on the first month after the operation, 70%. Then we get others which are occurring, later on, but most of them, they occur on the first month. What does it mean? Can you still hear me?
Yes.
Oh, thank you. Okay. So it is generally accepted that the majority of the shunt infections, in fact, they are secondary to colonizations during surgery, which is very, very important. Okay. We knew that, but somehow we didn't pay attention much to that. The late shunt infections are very, very rare. And you can see the publications which were done, particularly where the studies were done, like in Marseille. And you can see that the late infections are rather very, very rare. So when we talk about shunt infection, we have a lot of questions. There are a lot of controversies, evidently, and there are problems. What is the treatment? About the treatments, we've seen all kind of treatment. Shunt impregnated with antibiotics, and we've seen quite a lot of things, and they get more expensive and more expensive. And we know the consequences of the infection, the cost, and when you come from countries which are economically challenged, it becomes even a big problem. Even countries where there is a availability of all the materials and so on, but the poor person, the person who is economically challenged, still has a problem. So I think prevention is really the solution. And we've been working on that for a long time. The risk factors, there are many of them. We all know all of them. But the problem is, how can we prevent? We wrote a paper called Towards Zero Infection for Ventriculoperitoneal Shunt Insertion. And I'm just showing you where I work in Zimbabwe, here in red. And it is in Africa. And this is our medical school. And then you can see here Zimbabwe. And I work in this city, the capital city called Harare at the University of Zimbabwe. And as you can see, we do a lot of shunt, and we had even designed our own local shunt, which is called Harare valve shunt, which is working very well, and it performed very well when it was tested in Paris with the shunts, which are more expensive, and it worked really very well. And it's very, very, it's not very, very expensive, and everyone can afford it. This work, I did it together with all of my students, and you can see here Esene from Cameroon, Zoa in Zimbabwe, and Musara from Zimbabwe. And you can see here Badra, who is working in Namibia, and then Jeff, who is working in Congo. And it was basically a study which was done in several countries. So I wanted to find basically a method which was pragmatic, cost-effective, and evidence-based protocol. We know by experience, in fact, by chance, as I told you, it was like all discoveries, they come by chance, is that the global infection rate varies between 3 to 20%, and in some publications, it is even more. In fact, we got our infection rate, which is inferior to 2%. So I'll tell you how we got to that. As all we know epidemiologically, that hydrocephalus is the most frequent surgical problem accounted in the world, particularly in third world countries, and is the commonest pediatric neurological disorder. And in some countries is actually the #1 operation people do in their hospitals. Of course, we have managed, we have the way of managing hydrocephalus. We have a therapeutic armamentarium for hydrocephalus. Ventricular peritoneal shunt is the most sort of popular, but we have also new methods like endoscopic third ventricular stomy, but conventional CSF shunting is still a treatment option with excellent prognosis and for many hydrocephalic patients. Ventricular peritoneal shunt, as we all know, has improved quality of life of many patients. However, it comes also with a lot of complications, the morbidity like malfunction, and of course shunt infection we are talking about, and see how we can reduce that. And of course, the mortality rates are still elevated, ranging from 10 to 15% to as high as 30 to 40%. And mostly all those mortality rates are actually around this infection rate, most of the time. So we wanted, evidence-based protocol to mitigate morbidity and mortality. We are not inventing anything. There are already a lot of protocols which have suggested what to do to reduce the infection rate. But to reach 0 infection rate, is still a far cry. Early infection after VP shunt is still within 3 to 20%. And the current acceptable infection rate, where we say that, this team is performing very well, is between 5 to 7%. As we said earlier on, the 50% infection occurred within 2 weeks. And within a month, we have basically 70 to 90% of the infections. The others then they can occur later on. So we wanted this mitigated protocol, which was adapted to our African protocol, because all the other protocols, they can work very well, but still they are very difficult and sometimes impossible to apply in our settings. I will discuss that later as well. So we did a multi-center prospective cohort study, and 209 under 5 children, under 5 years children requiring VP shunt were incorporated. And in our protocol, now I'm telling you what we are doing, we insisted on intermittent application of povidone iodine on the skin during the operation. That's the only change we added, and according to the statistics we did, that's the only factor which really mattered to improve our infection rate. And we followed, of course, our patient after 3 months post-surgery. All those protocols, of course, was applied in all those 3 countries which collaborated with the study. Now, the protocol to minimize VP shunts, as you can see, there is a long list which is appearing to you. And these long lists, I'm not going through everything. And most of the things are already done elsewhere, but still they haven't actually reduced significantly the infection rate. But I will go through them. Some of them we know shunt is done in the morning, and neonates, infants are done before all the patients. And of course, no VP shunt will be done in an operation where a patient who was infected was actually treated. We shave patient with the razor in operating table. I know there are people who do not shave, but we still shave because we do not have always specialized nurses who can do that in the ward. So we do it ourselves into a theater, and by shaving, we don't have more infection. It works very well. Patient's chest, abdomen are shaved like the scalp, and we wash with 7.5, soap, povidone iodine soap, and later on, 10% povidone salts on the skin is put on the skin to scrub before draping. We don't use adhesive draping, not at all. And we will discuss about it in the discussion. I would be happy to answer this question. Then before we start the operation, we do again a third skin wash of 10% povidone iodine solution. Now, this is what we do, which is different for all the other protocol. We put intermittently povidone iodine 10% every 20 minutes. Okay. Why every 20 minutes? Because studies have shown that the colonization of the skin occurred around 25 to 30 minutes after you've put the povidone iodine. So to prevent that colonization to infect our shunt, we put this iodine povidone every 20 minutes. Not only that, so we keep our skin moist all the time. So this is a paradigm shift. Usually we try to dry the skin. We leave the skin wet. So one has to be used to this new kind of situation, and it works very well, and you get adapted very well. Then we have other things which are done in other protocols, like prophylactic antibiotics. We give that injection anesthesia. We use double gliding gloves. The shunt opening is delayed until the time of before insertion. I think all those measures are also used in other protocol, which never managed really to reduce completely the infection rate. So, so is the ventricular catheter, which is placed into the ventricle. I'm just showing you that the other things were done like any other protocol. We do meticulous hemostasis as usual, and the antibiotics are continued for 3 days post the operation, and sterile dressing is removed on day 3, and after that we change the dressing every day, because we know our patients, they sweat under that dressing. So we tend to dress these patients on a daily basis until removal of the stitches. That's also something very important. Now I'm showing you here the scene on a theater. You see here on the left-hand side, that's the ideal situation according to the protocol by Professor Shooks and Botolesi. But in reality, this is what's happening in our hospital, teaching hospital. You see there are students here because they have to attend and see those operations before they can write the exam. So therefore they can be admitted. So from only 5 people into theater here, this is a private hospital, so we can afford to do that. But in the teaching hospital and almost in the government hospital, we cannot afford that. Minimum, we have, up to 15 people in the theater. So this is showing you just the number of patients who were operated, 211 shunts which were performed, and 209 were analyzed. And those are the results. And one can see them very well into the paper. They are well described. And something also very interesting, and which is differ a lot from the study which was done in Uganda, where the cause of hydrocephalus is whether you go to Zimbabwe, Namibia, or DRC Congo, most of the patients had non-communicating hydrocephalus. Then others, they had communicating hydrocephalus. So the infection wasn't actually the major cause of hydrocephalus, like which was described in Uganda by one of our colleagues. So aqueduct of Sylvius, aqueduct stenosis was the most frequent cause of non-communicating hydrocephalus, about 84.9%. And post-infectious hydrocephalus was only on the 44% of patients. And the results of operative factors, there are details here. I don't want to go into details to prolong this talk, but everything is in the paper we wrote. And the infection we had was in 4 patients, and that was 1.9% per procedure. What are the results and outcome? Other post-operative complications where we had patients who had cerebrospinal fluid leak, which developed in 2 children. We had a stitch abscess in one of other patients, but these were not the children who eventually had shunt infection. On this table, you can see the protocol from Professor Shooks, and everybody knows it, okay, where he's advocating only 5 people in theater. And in fact, they got very good results. We really admire this protocol, but it is impossible. The second thing also they do is that the shunt is done by a senior person so that it takes less time. But in our protocol, even junior people who are able to operate, but they take more time, of course, but this didn't actually affect our results. And you can see here other protocols. And this is our protocol, which reduced our infection rate to 1.9%. So this is the paper we wrote, and the observed infection rate. This suggests that the protocol followed captured the most critical component necessary to ensure low infection rate. And it is simple measure which can be implemented in economically challenged environment. And we hope it may achieve internationally acceptable infection rate. Thank you very much.
Thank you very much. Professor Sridhar.
Yeah, thank you, Professor Kalango. That was extremely interesting. And at the outset, I think I must congratulate you on your extremely low infection rate following shunts. I think that's a job wonderfully done. I think that is tremendous. Okay, now for discussion. Let me ask you a question, which sometimes we find quite challenging, is the nutritional status of the child, which comes to us. Sometimes these children are with a large head, quite thin, malnourished. Do you think nutrition plays a role in the development of infection in the shunts?
According to the literature, yes. But according to our study, we had also children who were malnourished, but they didn't get the infection. So malnourishment is not actually a factor which will influence infection. The infection is caused by surgery. And once you apply that protocol where you work on a wet environment, where you put your Providone every 20 minutes. You avoid infection, whether the child is malnourished or not.
Another question of mine is that traditionally we've been all taught. I mean, I come from an era when we did not have povidone iodine, and we used other things to, I think Purohit will also know, we used other things to clean up the skin before we operated. The povidone iodine is supposed to be left there to dry. And that's when they say the most bactericidal effect of the povidone iodine will be available to prevent infections. But what I'm hearing you say is that you need to do it every 20 minutes to make sure that the skin is wet. Is that right?
Correct, yes.
Which goes against the traditionally taught thought that we need to dry the povidone iodine, because most often we teach residents when they're draping that you paint and let the povidone iodine settle there and dry before you start your draping. So how is this? This is almost a very controversial statement.
What's happening is when you dry the skin, you'll see immediately after, let's say 5 minutes or so, you can see actually the patient sweating from the skin. And if bacteria are hidden into the sweating glands, and they come and start to colonize already the skin. So when it is wet, it continues to work. In fact, that's what we saw in our paper, in our setting in hospital. And in fact, we took also some samples, for culture, and we saw that nothing grew when it was wet. And in fact, the results are confirming that you don't have to let the actually Providone to dry. What you need is actually to keep the Providone present all the time. When you dry it, I think that's when actually you give the opportunity, the gland to sweat and bring new bacteria on the skin.
So would you say that the operating room environment, meaning the temperature and the humidity, has a role to play in this whole scenario? Because you are looking at the child sweating from the skin. So if you have a temperature, so we need to balance small children, which you are operating, keep it at a temperature when they won't sweat, but at the same time, you need to prevent hypothermia in these children, because as you know, their surface area is quite big, and therefore they easily go into hypothermia. So what is the temperature in your operating room, and what is the humidity that you keep in your operating room?
In the best scenario is to have, of course, a room with air conditioning, and the temperature is usually between 20 and 22 degrees. Okay, but most of the time, this actually system doesn't work. In fact, if you saw carefully that picture I showed you, where there were many.
Had a fan in it. Yes.
Exactly. That's what we use most of the time. In fact, we couldn't believe that by doing that, that we would have low. In fact, we're expecting to have a lot of infection. And we can see that, in fact, the number of people in theater, the environment, the temperature doesn't affect at all. By doing that, it's like, you actually remove completely all those factors which were causing infection. And in fact, by doing this operation in those 3 countries, in Congo, for example, we went in hospitals where the conditions were really below the standard. The only thing we had was actually Povidone.
Can I ask a question?
Yes.
I think Dr. Purohit has a question.
Yes.
Thank you.
I appreciate this was a very interesting talk and very good results. And
Dr. Purohit,
thanks
please.
to, yeah. Am I audible?
Yes, sir, you are.
Yeah. So
Yes.
after giving you thanks, I would like to mention that what I practice is even before the patient or the child, any of the cases which I operate, even for the limbs which are totally exposed for a long time during the SPR also, or the SMF, for the shunts, etc. also, or any of the craniotomy also, the patient is given a bath in the their ward, and 3 times after the cleaning with the soap, 3 times povidone iodine is dried up on their body. If I am not operating on the head, say below for SMF, then 3 times on whole of the body, they have to dry it. Now, when any sweat comes, this get diluted, this dried povidone iodine will act on that sweat also. So a thin layer of dried povidone iodine perhaps is better, because if I put the iodine solution during the surgery, there are chances that it may drip into the wound also. Whatever we may do, there are so many kinds of the, even the students will be there, whether this wound opened there, when you put it, something may dribble into the wound. So I think still it will be more important than dried povidone iodine. Sweat comes, get the dilution through the iodine layer which is there on the skin surface. Have you done any study where this was not a wet skin, it was the dried povidone iodine skin, and what were the results? Over to you, sir.
Yes, thank you very much for the question. It's very, very interesting. What we do, in fact, as I told you, we work in wet environment. And actually the providone is put also in the wound. Okay. And we have this saying, of course, laughing and making it as a joke, that we are getting rid of bad spirits. So if each time there is a wound, we put providone in the wound as well. Okay. So where we put every 20 minutes is of course on the skin, but in the wound, it just once and then does it. The wound doesn't remain open for a long time in any way. Okay. So of course, patients are bathed before they come to theater. But the fact that they are bathed doesn't stop sweating. And this sweating is, of course, is natural, is physiological, it's important, but it brings with it the bacteria, which are hidden into the, there's a very nice paper which is written on that's where you get the recolonization. Okay. Now, your dry providone, of course, is very good, but the only thing is that if you look carefully, you see that where the patient is sweating, they are like a small pen and like small lamps, you know, lights, you know, because that's where the sweating is coming. So, and that's where the colony of bacteria start now to recolonize. And the recolonization, of course, it starts after 25 minutes, generally, but it continues. And the bacteria, eventually, they become actually in majority. That's when actually we get now the infection. So we see that what we've done has, of course, given us these good results, and we've repeated this experience in 3 different countries. Right now, we are conducting also the same protocol in other countries, and we'll be happy, of course, to do that with other colleagues, you know, with you or anybody else, and so that we confirm that. I don't have, of course, all answers. I know that by doing this, our infection rate came down. In Zimbabwe, came down. In Namibia, and came down in Congo. So, but we don't have all the explanations.
Thank you.
Professor Kalango, I then have a final question of mine. What is your opinion of antibiotic impregnated shunt systems?
I'm sure they have worked in those countries where patients can afford that. Of course, it can be used, but we cannot afford it because the majority of our patients, they cannot afford that kind of shunts. They are too expensive. Of course, if I had them, I would use them. That's not the problem.
Okay.
They've given up with good results. I'm not saying this technique should actually exclude completely what was done before, not at all. It's not this technique against others. I'm just saying, but just adding this little thing, which is simple, which anybody can do anywhere and everywhere, these are the results we get.
So I have one more question, sorry. Do you put the shunt tube in a bath of povidone iodine before you put it into the subcutaneous tunnel?
No, not at all. We don't do that.
Why
What we
not?
do,
Why not?
we
Because you feel that the povidone iodine is helping reduce the infection. So maybe if you do that, maybe anything which has escaped from the skin and gone in, anyway, povidone iodine is going into the wound. So why don't you do that?
well, it's a very good idea. We'll try it, but so far, because we still have 1.9%, so because we want to have zero infection. So maybe by doing that, we'll have zero. Definitely, we'll try it and see.
And then you can call it Sridhar modification of the Kalangu protocol.
Absolutely, absolutely, absolutely.
So we are moving from
Just
try
joking,
to wait.
just joking.
So try to wait is the question now.
Right.
Okay.
I think, are there any more questions from anybody else?
Definitely, I would like to add on the point that Professor Sridhar mentioned. We in Trivandrum, one of the largest centers that we do VP shunt, and as Professor Sridhar said, we definitely keep these shunts into a bath of saline with gentamicin. One antibiotic is usually there, and we never take this shunt out of this bath of gentamicin unless it is the time of tunneling. Even when tunneling, we keep this bath with gentamicin just besides the head, and this is slowly tunneled, and while one end is drawn from the abdomen, this is gradually fed into that tunnel. This is how we do it here. And moreover, we change the gloves regularly. That is exposure one gloves, shunt assembly one glove, then shunt passage another glove, and closure another glove. So by following these two methods, and when after passage of the shunt also, the leftover gentamicin is regularly irrigated over the wound in the cranial region. That is what I would like to mention. Any other remarks that Professor Sridhar or Professor Purohit would like to say?
I would believe on the shunt which has been delivered to us by the company is the most sterile. I am actually afraid that whatever we mix from our OT, perhaps somewhere something might get contaminated. So I'm scared. I would directly take from there in a most dry of this sterile place, minimum touching to the any other thing, and then to pass into the ventricle or into the abdominal side. But I would be very much afraid of believing anybody in the operation theater than the sterile material sent by the company. Over to all of you.
I think Professor Purohit has raised a very, very valid point. We often, have saline baths, but they are kept open. They're not a closed system. And therefore, what Dr. Purohit says is very valid. And especially if you're using antibiotic impregnated shunt tubes, you are not supposed to put it into a bath of antibiotic solution. You're supposed to directly put it into the body, and that too with a no-touch technique. You're just supposed to use forceps and handle the tube. and the less you handle the tube. Anything to say?
Oh, definitely. I think the remark you made, Dr. Raja, is very important. Basically, what you are doing, you are trying to bypass the skin, the touch of the skin, so that basically you are almost doing the same, only that it's not easy for everyone to bypass the skin. There is always people who are going to touch the skin and again touch then the wound or touch the shunt. But if you can technically bypass the skin, then you won't have infection, of course, because that's where the infection is coming from. But I like your technique as well. It's very good. If it can be implemented, I mean, that would be fantastic.
Thank you. We can go to, yes, Leo, would you like to say anything?
Yeah, thanks, Raja. Professor, I have a few questions to ask, Professor. Do you think that the result in your trial is due to the trial effect? I mean, because it's not blinded, so everybody are prepared the best condition for the trial. It it happen? Does the same result that you get after the trial? My first question: do you think that effect are due to also age group? As we know that adult less chance to have shunt infection than the pediatric. My second question is actually I came across a paper regarding two things. One is a povidone would not sterilize the skin. So how whatever amount povidone that you use, the skin cannot be sterilized. And also there is also paper regarding povidone bottle contamination. That's why in my elective case, whenever I want to close the skin, I will ask a new bottle, but I can't be asking for all the time. So do you come across that infection in the multiple use povidone bottles? My third question, last question, Professor, in changing glove, because some gloves are with powder, some without powder, and there's a good belief that a powder also causes contamination and infection. If you use powder, do you really wash with saline before you handling any device or shunt device? Thank you, Professor.
Thank you very much. For your first question, all those three countries, three centers, we knew the infection rate before. So what we did is just say, fine, patients are coming in anyway. Patients are plenty, they are there. So let's just change and follow this protocol. That's what we did. Now, this is the reason why we saw those good results. And as I said before, we're extending this study in other countries to challenge, of course, this protocol and see whether this protocol is really valid and can be validated by either colleagues and in other countries and so on, so that we can say, oh, this is really a good thing to be done. That's very important. Regarding the providone, not causing, bringing sterility or not, it's a very good, remark, and I agree with you. I think the important thing is because when you talk about sterilization, we think zero bacteria, but in reality, is a reduction of the amount of bacteria which can be infectant, which can actually cause an infection. Because there are other people who do not have this providone, but they can use other possibilities. I grew up when I was young, we were using, alcohol with iodine. So these also can work. What about just with normal saline and cleaning the skin regularly? I haven't done that, but as soon as you reduce the amount of bacteria to non-infectant, probably we can have the same results. But so far, when we see our results, definitely we think it worked. But of course, we are open. If other colleagues would like actually to join us and do this experiment, we will be more than happy to do that. Because if we can solve this problem together worldwide, it will be fantastic, because you can save lives, money, and of course miseries for those kids. Regarding the gloves, yes, before we insert the shunt, we change the gloves. Now, our gloves, they have, of course, I mean, they have powder, but what we do always is the nurse gives us a swab which is wet, and then we always clean our gloves, so that if there is any powder, is removed. That's what we do. That's sort of routine in all operations in any way. I don't know if I answered all your questions.
Yes, thank you, Professor.
Now we can go back to our chair, Professor Sridhar, to hear his concluding remarks.
I think this lecture by Professor Kalangu has been something of an eye-opener. He has managed to reduce shunt infections, which are the bane of shunt surgeries, to a very negligible, less than 2% incidence. And we need to congratulate him on that. Shunt infections are caused by many reasons, and he has perhaps offered one insight into how they can be reduced. And thank you very much, Professor, for sharing your thoughts with us and answering all our questions very patiently. Thank you very much. And over back to you, Raja.
Thank you very much. We had a wonderful session. I think I will wind this up officially now. On behalf of the Education Committee of the ACNS and the President, Professor Yoko Kato, I would like to sincerely thank both the speakers of today, Professor Anirudh Purohit and Professor Kazadi Kalangu, and the chairs, Professor Liang Shen and Professor Krish Sridhar, for the time and support for the ACNS webinars. I would like to thank my co-host, Dr. Liu Boon Singh, and a special thanks to Professor Shubin, who has supported us throughout our journey, and he has arranged the WeChat broadcast of this webinar in China. We have today around 750 neurosurgeons who are watching this live on various streaming platforms like WeChat, YouTube, and Zoom. I thank you all who have joined. So until we all meet on the 21st, it is bye-bye. Thank you very much for joining.